Okay, it's just a little past 8 o'clock. I think we should get started. Thanks again for joining us. This is our second session in the series entitled Health Equity in Cardiovascular Risk. Please, a reminder not to disclose any private health information during these sessions. And here's the usual reminders about how to chat, and of course, any help that's needed. A little bit about cardio, which you've seen before, and this is the ECHO team. Today, we'll be hearing from Chris Taylor, and I'll be hosting as usual. And as you can see, we have a nice geographic representation as well. These are our disclosure statements for this particular series. And we will have a presentation well within the nutrition domain. And usually what we do, for those of you who are relatively new to ECHO, is we will ask a couple of our experts to chime in on the case study that Austin's going to present today, which I thought was really interesting. And then we kind of will open it up to discussion and questions from the larger group. Okay, so this is a very important topic: dietary preferences and their role in driving cardiovascular risk and obesity and everything that goes along with it. So Chris, the floor is yours. Take it away.
Excellent. Thank you so much. It's great to meet all of you. It's great to be back for another Cardio Echo series. And today I'm going to talk a little bit about different approaches to dietary recommendations that kind of come from around the world that help us kind of set a stage for what the nutrition recommendations are across various countries, various cultures, what kinds of differences we may see, especially here in the US, across racial and ethnic groups, and what kinds of things to consider when trying to factor in culture in making dietary decisions that all have an impact on chronic disease risk. So these are our objectives. So what I wanted to do was kind of start with the basis of where we have our nutrition recommendations in the US, and dating all the way back to 1943, the basic 7 food groups put together that kind of look very similar to what we've seen in the past, the 5 food groups. So those guidelines kind of carried forward. And then in 2011, these guidelines were then transitioned into MyPlate, but they're still really around the same core idea of getting a variety of food types, fruits, vegetables, grains, protein sources, dairy, to get this combination of the nutrients that we need throughout the day. We see this variation on a very similar theme. We got the food balance wheel for Koreans that mainly has grains, meat, fish, eggs, and beans, vegetables, fruits, and milk. We have very similar things within the Japanese food spinning top. So lots of different ways that we're seeing much the same type of breakdowns, getting a variety of food, different food types. But what we ultimately start to see within each one of these images are just slightly different food choices within all the same categories. So in some ways, when we're trying to address culture, dietary diversity, food preferences, and how they contribute to dietary intakes, we're really looking at a lot of the same types of recommendations across different countries, across different cultures. That makes it a little bit easier for us to have a common ground as far as starting conversations, because we're not looking to reinvent a dietary approach, but we're helping to understand within these same type of evidence-based guidelines, what are individuals consuming and what are ways that we can make quote unquote healthier choices to reduce risk for cardiovascular disease, reduce risk for chronic disease within the same type of structure. So as we've seen, international food guidance really just represents this variation on a very similar theme around dietary diversity, getting a variety of foods. A lot of them you'll see based on colors, really kind of promoting this consumption of a variety of colors on our plate, which really then help us with nutritional diversity of what we're consuming. We have a tendency in America to eat a lot of very white meals, white potatoes, white chicken, white noodles, so that lack of color then leads to a lack of some of the vitamins and minerals. Those carotenoids in the vegetables that really give them the color are sources of vitamins. So really that promotion of color and diversity we see across all of these different types of recommendations that really kind of bring that story to life around eating a healthy diet and a balanced diet. And one of the things, if you've been following the Dietary Guidelines Advisory Committee this past cycle, one of the focus areas that they've talked about during the public meetings has been around the health equity lens that the dietary guidelines is taking, and looking at the different ways that socioeconomic position, race, ethnicity, food security, all of these aspects have an impact on nutrition access and dietary guidelines. So looking at some of these different cultural food ways, what people eat and how they consume, kind of become that foundation of understanding that we need. And sometimes it just comes down to the conversation around some groups may have staple carbohydrate sources that are going to be based on grains. Some groups are going to eat grains, breads, pastas. Some will consume rice. Others may have potatoes or sweet potatoes as more of a staple carbohydrate source. So understanding where that foundation of the meal is coming from helps us really make more specific recommendations and help them translate this idea of carbohydrate, limiting carbohydrate, spreading carbohydrate out throughout the day, and what that foundational source is. Different types of vegetables and fruits. Basically, as you look through lots of different international dietary recommendation, we basically just see different types of fruits and different types of vegetables nested within that category. So understanding the sources of where they're getting vegetables, where they're getting fruits, what are the protein sources that they're consuming. Some of the cultural patterns may rely more on a vegetarian dietary pattern. So looking at what those potential protein sources, nuts, seeds, legumes, pulses, beans, peas, and lentils, does that make up the foundational part versus what we may see with different types of meat? Are we looking at groups that may eat pork, may not eat pork, may not eat poultry? So the composition of what we may see. And I just put a quick link in to a website that I found that has more specific details on like the halal eating pattern and what some of those limitations may be, or the restrictions that we have within Muslim dietary considerations, and understanding how to factor those in. So what I did want to take a step back and look at what we have currently within the US. These are data from USDA, Center for Nutrition Policy and Promotion. And the HEI Diet Quality Index is a numeric score that represents how well individuals are doing compared to meeting the dietary guidelines for the US. So if you followed all of the recommendations provided within the dietary guidelines, you would end up with a total score of 100. So a higher score is better. And what you can see is generally across the US, across different racial and ethnic groups, we're doing so-so. If this was a class, the class is probably not passing out of a score out of 100. So all of Americans, the average HEI score is going to be about 58. And we see the highest diet quality score within non-Hispanic Asians, and generally fairly similar across all of the other racial and ethnic subgroups. So next slide, please. So you can see we have areas for improvement. But what also becomes really interesting when you look at these numbers, looking at how Americans are eating across different racial and ethnic groups based on the NHANES data. The blue bar on the left is the maximum number of points. So for fruits, we have basically a total contributing point of 10, which counts 5 from total fruits, eating any fruit, and then 5 from whole fruit. So this recommendation of getting at least half of your fruit from whole fruit. And we can start to see differences across different subgroups in different areas. So our fruit and vegetable intakes have a tendency to be a bit lower in non-Hispanic whites and non-Hispanic blacks, where our non-Hispanic Asians are more likely to be consuming fruit and whole fruit, vegetables. Greens and beans gets us into green leafy vegetables and legumes, increasing fiber intake. As a whole, we're not doing well on whole grains, with about a quarter of the maximum number of points. The total protein and seafood and plant protein are a little bit deceiving based on the way that it's calculated, because seafood and plant proteins are based on a per week. But for the most part, we're doing much better in our protein foods category. The greens and beans and the whole grains are kind of giving us a little bit better picture around the fiber intakes than the seafood and plant proteins that are kind of adjusted on a weekly basis. And our fatty acids is our ratio of unsaturated fat to saturated fat. So the higher our saturated fat intakes and risk for cardiovascular disease, the lower our fatty acid score is going to be. So we can see where we have more challenges in the fat composition. Next slide, please, Rich. And then for the areas where we want to see moderation, so not too much on refined grains, limit sodium intake, limit added sugars and saturated fat. A higher score means a lower intake or a better compliance with diet quality. So with sodium, added sugars, and saturated fats, we have a lot of room for improvement. We see a poorer diet quality score in non-Hispanic Asians, but a better diet quality score for added sugars and saturated fats in non-Hispanic Asians compared to other groups. So it really kind of helps us see some of the food selection patterns and how they compare with overall dietary composition. So as we start talking about dietary restrictions, how do we plan for dietary restrictions, and really start opening that conversation about ways that we can make dietary improvements. Some of the important things to keep consider and ask questions are asking about modifications to eating patterns for various reasons. Some of them may be cultural. It may be avoiding meat products or dairy products or certain food groups because of cultural considerations. So it helps us better understand their cultural, maybe their religious or ethical reasons for food selection. And then that gives us a better way to then start to plan out getting the nutrients that they need, that they may be missing from certain groups, or ways to make healthier substitutions. There's also considering family and personal roles related to food, meals, meal preparation, participation. So thinking about not only just what's on the plate and the food, but also the meaning behind how it gets there, why it's there, and the social function that it serves. So it really helps us not only say, we think it would be great to make this change, but if we understand the implications that may have, we can then facilitate how to make these changes and how to make them in real life, compared to just kind of looking at, say, diet quality scores or nutrient values. Cultural traditions, holidays, frequency. This is another one of those that comes up, especially very commonly when addressing cultural food patterns. So from a show of hands or a thumbs up, how many are going to have some kind of Thanksgiving dinner? What, in a month and a half? Right. Do you have that more than once a year? Or is that really just the fourth Thursday in November, and so it's a cultural tradition. It's part of our social context. And I think one of the things that frustrates me most is how did they not derail your entire year with your one day of Thanksgiving that you're only going to do once and you're not going to do again? So thinking about what are some of the cultural traditions that may happen, the holidays. If the holidays and these types of celebrations are a regular thing, then it becomes far more challenging for the patient's long-term health outcomes. But if this is a once a year traditional holiday experience, it's part of their cultural tradition. Now we can understand how to respond to what happens and move forward with that, as opposed to ways that we may be trying to negatively impact and some negative perceptions around culture by trying to make recommendations and changes within these kind of single event types of considerations. Next slide, please. And then just finally, I wanted to anchor back, and I know this is something that we will talk about throughout. Adam will be speaking about this as well, I know, I'm sure. But looking at addressing health disparities that can look out beyond just cultural, beyond individual, but looking at the systems that are driving many of these health disparities, linked to inequities tied to socioeconomic position, access, and affordability. And we're keeping in mind that representation is how well do my foods show up. Equity gets into what foods do I have access to, or what foods should be there, and then access, can I make these choices? So thinking about the choice within these dietary patterns versus the what I can make happen for myself from the patient's perspective. So really, how can we help them make changes? On the bottom right-hand corner, I put up, I love this graphic. I remember this being presented live at the national meeting, but it's basically calories per dollar. So what are our cheapest sources of calories? So the top left, oil, shortening, mayonnaise, margarine, sugar, they're all the cheapest, higher calorie options, versus the lower right hand get to be more of our fruits, vegetables, fresh produce, more expensive calorie per dollar. So thinking about access, choice, and considering referrals. Some of these get into complex conversations around access, around food choice, around planning. So what is the team around you that you have, dietitians, social workers, what types of food assistance programs may be out there and available that will help individuals make these better choices? So I just put together a quick list of resources that will help you with various sources of information. And with that, I'll take any questions.
Thank you so much, Chris. Great presentation. Any questions for Chris before we move on?
Thank you. Very good presentation. I really enjoyed it. One thing you didn't have the opportunity to talk about was taste. I'm just curious, can you speak very briefly about how can you help somebody understand that the taste that they're accustomed to isn't necessarily the taste that they have to live the rest of their lives with? Is it possible to change somebody's taste preferences in a healthy manner?
And I think that gets into some of the challenges more specifically around what people are eating and how difficult it is to make changes. A lot of food selection is based on individual taste. As we eat different foods, it takes time to adapt. So if you eat less sodium, it's going to take approximately 3 weeks before you really start to kind of acclimate, and your taste buds will then start to adjust. So when you start making changes and eliminate things like sweet and salty, it's going to take about 3 weeks before the body kind of adjusts to that difference. But at the same time, using things like spices that allow you to get some of the flavor profiles without the sodium are ways that you can make adaptations to make healthier choices and still maintain the flavor, but reduce things like salt and sugar that and fat that may be kind of creating those. But it's like dietary changes are Newtonian. Every time you take something else out, you have to put something back in. So the what you take out becomes just as important as what you put back in. So like spices and seasonings can really help compensate for that without giving you the extra sodium and things like that.
Thank you. The 3 weeks thing is something I had not heard before. That's useful.
Thanks, Paul. Thanks, Chris. I think we can probably wrap things up with some announcements for next week.
Yep. So again, you can watch today's recording on the Cardio website, and you can also go back and look at old Echo Didactics if you want. A reminder, a post-clinic survey would have been sent to you a couple minutes ago. Please fill that out to give us some feedback on today's presentation by Dr. Taylor. We are still missing some case studies, so if you could please send those in. It helps us create the schedule so it's not so last minute. I did chat those of you who are missing them. And then if you have one that you've, come into your mind after you've heard the first 2 weeks, let me know as well, and I can send you a new link to submit an extra one. Let us know if you have any questions. Otherwise, we will see you next week.
All right, everyone, have a wonderful week, rest of the week and weekend, and we'll see you next week. Take care.